Good morning. Today we are going to see about the condition nephrotic syndrome. And first, nephrotic syndrome. The syndrome is apparent in any condition that seriously damage the glomerular capillary membrane that result in increased glomerular capillary permeability to the plasma protein. Although the liver is capable of increasing the production of protein, it can keep up the daily loss of albumin through the kidney. Thus, the hypoalbuminemia is result. And next we move on the definition. Nephrotic syndrome is a disorder that is characterized by proteinuria, hypoalbuminemia, edema, and hyperlipidemia. This occurs due to the excessive leakage of the plasma protein in urine because of increased capillary permeability in the glomerulus. And next we move on the etiology. Glomerular nephritis, diabetes mellitus, SLE, sarcoidosis, amyloidosis in kidney, cancer, trauma, infection, drugs, renal thrombosis. And next we move on the pathophysiology. Already we know etiological. Due to the etiological, there is the glomerular membranes become damaged. So once the glomerular membrane damage, it may cause the increased permeability in the glomerulus membrane. So it may cause the proteinuria. There in urine, the persons may eliminate 3.5 grams of protein urine. This increased renal catabolism of albumin leads to hypoalbuminemia less than 3.5 grams per daily, and this may leads to the decreased glomerular oncotic pressure and then compensatory synthesis of the protein, including the lipoprotein, by the liver. This decreased oncotic process may lead to the fluid escape in the tissue that may cause edema, and then it also affects the decrease the plasma volume. So once the plasma volume decrease, it may decrease the glomerular filtration rate and then increase the aldosterone. So here the sodium retention will be there. The patient may experience the anasarcoma, that is a generalized edema will be seen, and the patient, the liver catabolism makes due to the low level of protein. Here the patients may experience the hypolipidemia. Through this pathophysiology, it comes to know the patient is having sarcoma and then edema. So next we are on the clinical manifestation. In that the patient may experience the proteinuria. Already said 3.4 grams of protein daily protein will be elimination. And the next hypoalbuminemia, edema. In edema, the patient is having the periorbital edema, pitting edema, angle edema, ascites, pleural effusion, weight gain, hypertension. So I wish to say what is meant by pitting edema. Here the pitting edema is over the lower extremities face. And the next, the patient may experience the fatigue, headache, malaise, irritability, foamy appearance of urine. This may due to the decreased surface tension by the severe proteinuria, hematuria, thrombophilia, clot formations, and then lipiduria, dyspnea, and then anemia. These are the clinical symptoms we can see in the patient. Followed by this picture shows the puffiness around the eyes, especially in the morning, and then pitting edema. Second picture shows the pitting edema when we are palpating the lower extremities. There is a edema will be present, pleural effusion, fluid accumulation in lungs, and then ascites, hypertension, anemia, dyspnea, ESR rate will be elevation, anorexia, loss of appetite, and then the child, those who have the nephrotic syndrome, fatigue, they feel fatigue, abdominal pain, and then some children they are experiencing the diarrhea. These are about the clinical manifestation. Next we are move on the diagnostic evaluation. In diagnostic evaluation, we have to ask the proper history to the parents, and then physical examination we have to do. In physical examination, we have to check whether they having any pitting edema or anosarcoma. Urine analysis here we have to do. Serum chemistry, creatinine clearance tests, needle biopsy of kidney. These are the investigation we have to do for the nephrotic syndrome. And next we move on the management. In management, we have to provide the symptomatic management for the edema. Here we are providing the adequate rest, nutrition, 1 gram of protein per kg. If the baby is having 10 kg, we have to provide the 10 grams of protein per day, not more that. Sodium restriction we have to provide, water not greater than the level of diuresis, and then medications. Here we are giving the diuretics in the diuretics, especially here we are administering the loop diuretics, example Lasix furosemide, and then hypoalbuminemia, moderate intake of protein, rich in animal protein, and then hyperlipidemia. Here we have to provide the low saturated fat, high unsaturated fat. If we are not responsible for the nutrition therapy, we have to provide the, and the next followed by the thrombophilia. Here we are giving the heparin, and then here we have to provide the antibiotic AC inhibitor for controlling the hypertension, achieve the better glucose level, and the kidney for the prevent the kidney damage. We have to provide the corticosteroid, especially we are giving the prednisolone. So nephrotic complication, here the infection, thromboembolic complications, pulmonary edema, hypovolemia, growth retardation, altered metabolism, ESRD. These are the complications we can see in the nephrotic syndrome. And the next management, here we have to provide the